Somebody pulls it.
We're going to call the Committee of Health and Human Services Reform to order, and we have a quorum present. So first order of business is to move the minutes for March 20th and 24th, which are in members' packets. So I have a motion to move the minutes. Representative Pearson moves the minutes for March 20th and March 24th. All those in favor say aye.
Aye.
Those opposed, no. The motion prevails. Members, our first bill up is House File 1843. Representative Smith, welcome to the committee.
Thank you, Madam Chair. And in the tradition, I have treats for the committee.
Oh, for crying out loud. Well, we like you today, Representative Smith. We're off to a great start. And I see they have a spring theme to them. That's very much appreciated.
We are eternally hopeful, Madam Chair. Madam Chair, members, thank you. House File 1843 is a bill about mobile food shelves. There's a growing number of people in Minnesota who experience barriers accessing food shelves due to mobility issues, disabilities, lack of transportation, and being far from a local food shelf. By delivering foods directly to apartment buildings, churches, community colleges, and low-income neighborhoods, the mobile food shelf programs increase access to nutritious food for people with barriers. There are many benefits to increasing mobile food shelf programs. It's cost-effective over building actual physical structures. It reduces stigma for seniors who need the food. And it's very effective in rural areas where food shelves are not nearby. Now I'd like to have the first of my three testifiers provide testimony, Madam Chair.
Okay, and just briefly, Representative Smith, I'm just going to move your bill so it's officially in front of us. So I will move that House File 1843 be re-referred to the Committee on Health and Human Services Finance.
Thank you.
And so with that, we'll go to testifiers. Welcome to the committee. If you could introduce yourself and then proceed with your testimony.
Madam Chair, committee members, good afternoon. Thank you for this opportunity. I am Elizabeth Johnson. I'm the Executive Director of a food shelf called Cross. Cross serves the communities of Champlin, Corcoran, Dayton, Maple Grove, Osseo, and Rogers. We have been in that community for about 38 years. The food shelf was started, our food shelf, like many food shelves, were started to address hunger issues and housing instability issues in our communities. Our service area, across the service area, has a population of over 113,000. It has seen a 26% population growth over the last 10 years, and we are on track for another 19% population growth in the coming census. Our service area, our agency covers over 226 square miles. Over 226 square miles, and only less than 15% of that area has any public transportation. So over the last 2 years, on a very limited basis, we have been partnering with the schools in our area. We've been partnering with senior housing complexes, mobile home parks, to increase our outreach into the community for people who cannot get to the food shelf. Our food shelf numbers are about 2,000 people a month. We serve about 2,000 people a month within our food shelf walls. And with our outreach and our outreach partners, in the last 2 years, we've increased from serving 2,000 people to serving over 7,000 people in the last 2 years. And the additional program, the additional individuals are through our mobile outreach. We have done this outreach due to lack of transportation, senior populations, people that are homebound, circumstances that don't allow them to get to a traditional food shelf. We are barely tapping the surface on the people that need our programs. They're building more senior programs, more affordable housing programs. All of those things are happening in our community to manage the growth of the population. But the infrastructure of transportation is not being addressed. And so although people are moving into our community that have need, we still have an access problem to the food shelf. And we cannot expand our outreach program any further than we already have without additional transportation and safe transportation equipment. So within the walls of our food shelf and with our outreach programs across, we distribute over 65,000 pounds of food a month. Over 65,000 pounds of food a month is coming out from just our one food shelf. And 25% of that needs some level of refrigerated transportation in order to get it safely into our outreach programs. This is a very simple, straightforward, one-time need. There's hungry people in many of our cities that cannot get to a traditional food shelf. This one-time equipment funding need to help outreach programs will provide years of outreach opportunity to feed hungry people in our communities that cannot get to a traditional food shelf. Thank you very much.
Thank you so much for being here. Is there anyone else who is here in the audience who wants to testify to the bill? Or Representative Smith, do you have other testifiers?
I have a second testifier, Madam Chair.
Okay,
Thank you.
wonderful. Do you want to come forward now? Welcome to the committee.
Thank you, Madam Chair, members of the committee. My name is Peter Whitezock. I'm a community organizer with Hunger Solutions Minnesota, and I appreciate the opportunity to testify on behalf of the Mobile Food Shelf Grant Bill, House File 1843. Representative Smith and Liz Johnson already described and gave a really good summary of the reasons why these mobile food shelf programs now exist to help bring people food to people's homes. And it can be apartment buildings, low-income neighborhoods, churches around the state, and we work with many of the mobile food shelf programs that do this great work. There are currently 9 mobile food shelf providers that are distributing over 1 million pounds of food to 50,000 individuals across the metro and statewide. And so we have heard from many of the food shelves, though, that those needs are growing. And so that's why we're working on this bill to address those needs. And that's what this bill would do is really get the resources to many food shelves to either start their own program or help our existing network of mobile providers to help expand to other areas in need. The money is set up to go through Hunger Solutions Minnesota to distribute as grants. This is something we already do with the Department of Human Services in the contract we have with them, where we distribute around $2.5 billion grants to food shelves around the state, and we have a 15-year track record of doing this work. And so mobile food shelves are really a hunger relief tool that can be expanded throughout Minnesota and can be a model to the rest of the nation. It would be a great step toward alleviating hunger for many seniors and others experiencing barriers to getting to their traditional food shelf here in the metro and throughout the state. So we encourage you to support this bill, and thank you very much for the opportunity.
Thank you so much for taking the time to be here.
I have one more testifier, Madam Chair.
Okay, Representative Smith. Welcome to the committee.
Thank you, Madam Chair, members of the committee. My name is Byron Lair. I'm Vice President of SEAT, Community Emergency Assistance Programs. We operate 2 food shelves, one in Brooklyn Center, one in Blaine. I won't repeat what you've already heard, but the needs are growing for people, and transportation is an issue. Even though our 2 food shelves are located in a human service center co-located with the county, Anoka in Blaine and Hennepin in Brooklyn Center, we find a number of individuals don't have transportation access. Even though we're on a bus line, buses really aren't convenient for grocery shopping. And when we look at opportunities to get food to the people in need, a mobile food shelf makes much more economic sense than trying to find other permanent facilities and equip them with refrigeration, et cetera. Like the other 300 food shelves in Minnesota, we have become very good at accessing and resourcing food and recruiting volunteers. Getting the capital funds to purchase a minibus and retrofit it, however, is another matter. House File 1843 would take care of that problem, and because we have access to food and volunteers, we would be able to sustain those mobile food shelves for years to come. Thank you very much for the time today, and I encourage your support.
Thank you so much for being here. So I'll ask at this point if there's anyone else in the audience who wants to testify to the bill. Not seeing any, we'll go to member questions. Representative Loeffler.
Well, thank you, Madam Chair. And I mean, I think this has proven to be a useful model in all kinds of different places. And I'm aware of one that works in the Twin Cities that's connected with a charity-connected brewery product, and operates a bus and has both collects and distributes food. My question is, you know, we have Second Harvest that distributes food. We have this bill is directed to Hunger Solutions Minnesota, and the funding would go to them. And not knowing sort of the organizational distribution structure within Minnesota, is why would we choose one group or another? Why is this the appropriate location as opposed to, I don't know, one of the state agencies taking the grants, that sort of thing? I just don't know if there's a bias between organizations or competition. I just want to have it on the record if there's some tension points that some of us might hear about later, because there's sometimes been, I know, different networks within this business, and I've been involved in some of the tension between different networks. So I'm just trying to find out if there's kumbaya in the community or not.
Representative Smith. Oh, Representative Smith.
Yes, well, I'll have the testifier answer that, Madam Chair. Thank you.
Madam
Thank
Chair
you.
and Representative, Hunger Solutions and Second Harvest, as well as the food group, work very well together on issues like this. In fact, we developed our proposal in consultation with Second Harvest. The reason the funds would be flowing through Hunger Solutions is that they already distribute the monies that go to the existing food shelves. So you don't have to create a new administrative structure. And even though these funds are not for the purchase of food, food shelves like mine and Cross and the other ones around the state actually purchase the food through Second Harvest. So I don't think you have to worry about a lack of kumbaya.
Representative
Thank you, Madam Chair. We always like to know everyone's working together in harmony.
Members, any other questions? Seeing none, I will renew my motion that House File 1843 be re-referred to the Committee on Health and Human Services. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Smith, and thank you so much for the treats.
Thank you, Madam Chair.
Okay, members, next bill is House File 1152. Representative Daniels. And members, we actually, we did have the hearing on this bill on Friday, and so just due to a paperwork error, we need to officially move it out of the committee today and vote on it. So we'll probably just have Representative Daniels just do a brief reminder of what we're doing here, and then we'll vote, being as we did have the hearing on Friday with questions and anything else. So Representative Daniels.
Thank you, Madam Chair. I appreciate you hearing us again, and we'll make it as brief as we can.
And Representative Daniels, I will officially move that House File 1152 be re-referred to the Committee on Rules. We have the bill in front of us. Representative Daniels.
Thank you very much. Our bill is just basically to get a study started to see if we can save some costs and time in the process of implementing vaccinations to healthcare workers. And it's a pretty simple bill just to get the framework started. And to speed up the process today, I'm going to turn over to our testifiers, and they're going to explain a little more about what exactly the bill does.
Hey, and Representative, we can, if the testifiers want to, because we did hear from them on Friday, unless members have any burning questions, the intention today is just to take action on the bill and move it along, being as we had the time on Friday. So, members, any burning unanswered questions on this bill? Okay, seeing none, I will renew my motion that House File 1152 be re-referred to the Committee on Rules. All those in favor say aye. Aye. Those opposed, no. The motion prevails.
Thank you.
Thank you, Representative Daniels. Members, next we are going to take up House File 507, Representative Murphy's bill. Welcome to the committee, Representative Murphy. I will move that House File 507 be re-referred to the Committee on Health and Human Services Finance. Representative Murphy.
Hey, Madam Chair and members, thank you very much for hearing House File 507. I know that there are a lot of bills in, and that you made time for this means a lot to me. This is a bill that will include Our Lady of Peace Residential Hospice Facility in the definition of residential hospice facilities. I have with me Mr. Joe Stanislav, and he can tell you more about the history of Our Lady of Peace and why this change is necessary. I want to call to your attention the fact that there is no cost to this piece of legislation. And then the bill is moving in the Senate. Mr. Stanislav is not a lobbyist. He does manage this facility, and it is a facility that is in the district I represent. And so I urge your support, and thank you very much for the time.
Thank you, and welcome to the committee. If you want to introduce yourself.
Thank you, Madam Chair. Joe Stanislav, I'm the administrator of Our Lady of Peace Home here in St. Paul. Pardon me, I'm fighting through Minnesota's common cold today. So, I would mention that for 74 years, Our Lady of Peace Home has been the only nursing home in Minnesota that has offered totally free care to every patient that it served since then, since Pearl Harbor Day. The home has been regulated as a nursing home, even though it cares exclusively for those at end of life. No, it has. In fact, our lengths of stays are less than 2 weeks right at this point in time. The Minnesota Nursing Home Association and the Hospice Association both support this change regulation from nursing home to residential hospice for this facility. The reason we need the bill change is because the hospice regs limit the size to 12 beds, and Our Lady of Peace Homes is 21. The bill you're considering today would cause Our Lady of Peace Homes to be correctly regulated and Medicare certified. Just finally mention that there is a companion bill in the Senate, and it did pass through the Senate House and Human Services Committee unanimously. Thank you for considering this bill.
Thank you so much for taking the time to be here. Is there anyone else in the audience who wants to testify to the bill? Okay, not seeing any members. Any questions? Okay, sounds good. Well, thank you for being here. With that, I will renew my motion that House File 507 be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. Motion prevails. Thank you, Representative Murphy.
Thank you, Madam Chair, members.
Okay, members, the next bill up will be House File 560. Representative Albright. And Representative Albright will move that House File 560 be re-referred to the Committee on Health and Human Services Finance. And we have the bill in front of us. And Representative Albright, I believe there's a DE1 amendment that you would like put on the bill.
Madam Chair, there is. I'd like to move the DE1 amendment to put the
Representative Albright moves the DE1 amendment to get the bill in the order that he would like. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Representative Albright, to your bill as amended.
Thank you, Madam Chair. And members, the amendment that we've just put on the bill, what that does is removes the language that would have added significant administrative costs to the bill. We've decided to concentrate rather on rolling back the premiums to the 2011 levels, which is the main problem for people affected by this malady. So as we talk about the bill itself as amended now, the bill removes the large increases that in premiums for persons with disabilities. We're trying to become more independent by using the medical assistance for employed persons with disabilities option, which is called MA-EPD. MA-EPD allows persons with disabilities who have earned income to pay a premium for medical assistance rather than pay what's called a spend down of all their income to 75% of the federal poverty level, which is $730 per month. I might note that one of our committee members, Representative Zerwas, also has a bill, House File 559, which would raise that spend-down level. So we are trying to bring some aid to these folks on a couple of different levels. The two numbers comprising the premium are changed back to the 2011 amounts. The premium increase was adopted in 2011 during that year's budget deficit crisis, but had to be delayed until 2014 due to the Affordable Care Act and the provisions therein. Since that time, DHS data indicate that about 650 more people have been disenrolled than was typical for the same period before the premium increase. And so, members, with that, I am going to refer to my testifiers who can explain a little more about the specifics of the bill. And I do have a testifier who would like to speak, I think, very eloquently to how this has affected his life.
Welcome to the committee.
Thank you. Madam Chair and members, my name is Ann Henry, and I'm with the Disability Law Center at Legal Aid. And we represent children and adults with long-term significant disabilities across our state. First, we'd like to thank Representative Albright for bringing forward this issue. We are very concerned since the premium has been imposed on people in October. Now, remember, it was passed as part of the budget deficit deal after the shutdown in 2011, but delayed until October. So people are just starting to really get pressed in terms of paying the bills. And we've heard from a number of our clients who cannot pay their rent now, who cannot pay their van payment or get their lift fixed. It is simply really imposing a hardship on folks who are doing exactly what we want them to do, which is to work and become as independent as possible. We are also worried because the numbers are going down in a program that ought to be going up as the economy increases. This program has had a lot more people than it now has, and the economy's good. There are jobs out there. And I think we all understand our economy needs workers, and people with disabilities are really an untapped resource. And one of the reasons this is such a good work incentive is because people who need community support services like a personal care attendant cannot get that from employer-based coverage, and they can't even get it from Medicare. They have to get it from medical assistance. That's the only option unless they have enough to pay for it out of pocket, which most of these folks certainly do not. So this is a tremendous work incentive. Without it, people are really not going to be able to work and are going to remain much more dependent on many, many more programs. One thing that I would like to point out, I know that you're not considering the fiscal side of this, but it's important to note that the state cost of restoring those premiums or reducing them back to where they were in 2011 is half of the amount that these folks are paying, because every premium paid, half goes to the federal government. That's what happens on medical assistance because it's shared state and federal. So people are actually paying twice the cost to the state of reducing this premium, and that's, I think, something to keep in mind. So with that, we urge your support of this, and thank you very much.
Thank you. And if I could just ask a really brief question, could you tell us the numbers? You know, you said that they are down right now, what they are right now compared to what they have been in the past.
Yes, Madam Chair, it's a little difficult to tell exactly because data isn't kept exactly why people disenroll, but from the comparisons of the past 2 years disenrollments for these periods, it looks like, over 600 people. That the disenrollments have risen to that extent. They are not the typical disenrollments. And we know that the overall enrollment is going down at a time we would have expected it to rise because the economy just has more opportunities for people.
Thank you for that. To our next testifier, welcome to the committee. If you could introduce yourself.
Thank you. My name is Erica Schmiel, and I am here to assist. Jim is going to introduce himself. I will translate, and then I will read the testimony he has written. My name is Jim Carlisle.
I live in Spenddown.
I live in West St. Paul. I am a 78-year-old tax accountant. I currently serve the tax-paying public using the work incentive program called Medical Assistance for Employed People with Disabilities, or MAEPD. While working with this program, I'm allowed to pay a monthly premium to receive medical assistance, including attendant care. These services are essential to my independence. This program has allowed me to accumulate a comparatively small retirement fund, build a wheelchair-sized home, and purchase an accessible vehicle. The real estate taxes, insurance, and maintenance on these assets take much of my modest income. Then, last year, my MAEPD premiums jumped from $43 to $118 a month. That was a 277% cost increase while my income stayed steady. If these unexpected and excessive premium increases would be imposed on the general public, most people would be searching for lower insurance rates. People with disabilities usually do not have that option. MAEPD premiums must be rolled back to the pre-increase levels. Policymakers say they want to keep people with disabilities in their homes and engaged in the community because it is better for their overall health. This can only be accomplished by taking the legislative measures necessary to decrease the expensive insurance premiums to disabled people. Thank you for listening to my testimony.
Thank you so much for being here. Is there anyone else in the audience who wants to testify to the bill? Okay. You can come forward to the table. Oh, if you could just hold on 1 second. When you come to the table, we just need you to introduce yourself on the record and speak into the microphone. Welcome to the committee. If you could just introduce yourself and then proceed.
Sure. I'm Brant Fouch, and thank you, folks, for listening. I'm a 62-year-old guy with a brain injury, and I graduated from college after getting the injury, worked as an accountant for 20 years. Finally, things started going backwards, and the effects of the brain injury got worse. I've been living on Social Security disability income for the last couple of years, and when the MAEPD thing hit, it was really devastating because being on MA, an employed person with a disability, I had lost whatever it was that paid for my Medicare Part B premium, which was $104.90 a month, and all of a sudden I was paying $111 a month for MA. And so I got hit 200 and some odd bucks out of the $952 grant that I get each month, and it really hurt. It had been $56 a month, and I figured, well, I'll contribute that back to the state for my MA, but all of a sudden I was more than $200 out of pocket. I wish you'd support this.
Thank you for taking the time to be here.
Sure.
Members, any questions? Representative Quam.
Thank you, Madam Chair, and just the comment that I wish our budget process allowed us to work in the savings of on whatever the appropriate word for basically, if we don't have a viable program, these people won't be able to work, and they will go more fully upon the public programs, and there'll be more dollars taken out of the budget. So it's better for them, better for the community, and better for the budget and taxpayers to have them be able to be independent. And I just want to support this bill and the other ones like it.
Representative Liebling.
Thank you, Madam Chair. And, you know, sometimes you're right, Representative Quam, it costs money sometimes to save money. And our budget process doesn't always allow us to capture, and it certainly doesn't allow us to capture the impact on human beings. That's not in the numbers. But budgets are moral documents, as it has been said. And my question to Representative Albright, we heard from Ann Henry about how this increase in the premiums came about, and the GOP did that as part of the cutting when the GOP was in charge of the House and Senate. And I believe that, you know, we did have, I think $1 billion was cut from the HHS budget at that time, and we did have a deficit. And that was a decision made at that time, instead of raising any taxes, to do it all with cuts. Well, this year, the target for HHS, again, is a cut of $1.1 billion, in spite of the fact that we have a budget surplus. And so my question to you is, do you have any realistic expectation that we would actually fix the mistake from the last time when we actually had a deficit, because even though we have a surplus, your caucus has decided to allocate that to tax cuts? So do you have any expectation that this is actually going to be able to be funded? Because I think around the table, most of us probably think it should be.
Representative Albright.
Madam Chair and Representative Liebling, I appreciate your comments, and I think the testimony is that we've heard is very compelling, and I think as we well know, for all the members around the table, anytime you set a budget target, there's a competition for the best ideas and for the best opportunities to serve the residents of our state. And so just like any member around the table that has presented an idea in the form of a bill, we will all compete to be a part of the budget that is put forth by the Chair of the Finance Committee for Health and Services, and I'll be right in the mix with everything that I've got to try and act on behalf of the people that you've heard testify and strongly advocate for this program.
Thank you.
Any other questions, members? Okay, not seeing any. Representative Albright will renew his motion that House File 560, as amended, be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative
members.
Albright.
Thank you very much.
Next up, we have Representative Zerwas, House File 658. Representative Zerwas, would you like to move your bill?
Thank you, Madam Chair and members. I'll move House File 658 be referred to Health and Human Service Finance.
Okay, and Representative Zerwas, I understand we have an A1 amendment. Is that correct?
We do, Madam Chair. We have an author's amendment, the A1 amendment, to get the bill in the shape in which I'd like to discuss it today.
Okay, members, Representative Zerwas moves the A1 amendment to get the bill in the order he would like. All those in favor say aye. Aye. Those opposed, no. The motion prevails. To your bill as amended, Representative Zerwas.
Well, Madam Chair and members, it's buckle in, it's MA Day. So we've been talking a little bit about MA and Representative Albright's bill before this one, and I have a few here tonight. House File 658 changes who is responsible for collecting spend down payments from individuals on medical assistance. The bill proposes to shift this responsibility for spend down collections from the provider of the service to the state of Minnesota. Federal law provides states an option that allows people to qualify for MA if their income and assets are above the Medicaid income and asset level by allowing these individuals to spend down their income on services otherwise covered by MA. The current MA income eligibility level is 100% of poverty, and the spend down is 75% of poverty. So a person making 100% of poverty is eligible, but a person making that amount plus $1 would have to spend their income down to 75% on medical assistance expenses. When a service provider performs a service to someone with a spend down and then bills the state for the service, the state will pay providers only for claims after the spend down amount is met, and the provider is instructed to collect the remaining portion of their payment from the individuals they served as a part of that individual's spend down. Because the income and asset are unable to, our levels are subject to in order to access MA is so low, they often don't have or unable to pay the spend down portion to the provider. This leaves the provider without full payment for services that are already delivered. The provider either then has to spend significant staff time trying to collect payment or just absorbs these costs, which happens most often. Both options are leading to very difficult financial times and limiting their ability to provide consistent care services to others. House File 658 changes this current process by creating a new process where the state reimburses the provider for the full MA rate of the services provided, and the state then assumes the responsibility for doing the spend down collection. At this time, I'd like to ask David Hancock to explain why this legislation is necessary and the impact of this issue on his organization.
Welcome to the committee.
Thank you, Madam Chair, and members of the committee. My name is David Hancock, and I'm the Chief Organization Officer for ACRA. ACRA is a nonprofit organization that offers person-centered, self-directed home care services to people with disabilities and older adults across the state of Minnesota. ACRA currently serves nearly 4,000 individuals in 67 counties across Minnesota and employs nearly 4,200 individuals. I want to thank Representative Zerwas for bringing forward this very important legislation. As Representative Zerwas described in his opening comments, the current MA spend down process is one that is broken for both participants and providers. While having a spend down option here in Minnesota that allows individuals to access needed MA services is a very important part of our state's health care system, the way in which the spend down collection is handled and the very low income limits that individuals are subject to is problematic. We at ACRA, along with many other service providers, support shifting the responsibility for collecting the spend down payments away from the providers and to the state. Because as providers, we want to focus on being a good service provider and not be in the collection business. When we provide services to someone, we want our relationship with that person to be solely focused on the services that we are providing and not be put in the position of having to try to collect spend down payments from those that we serve, especially as the details of these payments, the amount, how they impact eligibility, how they change from month to month, and other technical details are determined by the state and not by us as providers. Additionally, as Representative Zerwas mentioned, due to the low income standards this group is subject to, some of them simply can't or won't pay their spend down. In addition to the high administrative costs that we at ACRA absorb in our work to try to collect these spend down payments, which can be incredibly time intensive based on the population that we work with, we also run the risk of ending each year with a high amount of uncollected spend down payments. Currently, for example, at ACRA, the amount of participant debt due to spend downs is standing at about $70,000. And of that amount, approximately $50,000 is in our, quote, over 90 days aged account receivables program.
We serve 12 individuals that owe $2,000 or more, and one whose debt is standing at over $5,000. With the limited amount of earnings and assets, these individuals will most likely not be able to pay this amount, and ACRA will have to write it off. Even if the recipient of services is able to participate in a monthly payment plan, they are rarely able to make sizable enough payments to get ahead of the debt, so it becomes perpetual. At some point, many provider organizations are faced with the very real possibility of writing off very large amounts attributable to spend downs as bad debt. I would like just for a moment to speak briefly to a broader spend down issue that is addressed in the next bill on your agenda, which is House File 559. We at ACRA and other providers strongly support increasing the income and asset limits for individuals. As you will hear when the next bill is presented, Minnesotans with disabilities and older Minnesotans are subject to lower income and asset limits than any other category of individuals accessing MA coverage. If adults and seniors with disabilities make $1 more than $973 a month and keep their assets below $3,000 to qualify for, they may keep MA services and supports. Now, being forced to live off of $729 a month, it's no surprise that some of these individuals simply don't pay or can't pay their spend down payments. We don't believe that as a state we should have people with disabilities and older adults forced to live in poverty or be forced to maintain an unnecessary level of dependency. There is no question that we all want people with disabilities and older adults to be able to live more independently in communities and homes of their choosing, with increased job options, raising the income and asset level for this group so that they can have access to a little more of their incomes and assets each month would help achieve this goal. I want to thank you, Madam Chair, and the members of the committee for this opportunity to testify, and I would ask for your support of House File 658. I would also stand for questions, Madam Chair.
Thank you so much for taking the time to be here. Is there anyone else in the audience who would like to testify to the bill? Okay, I'm not seeing anyone right now. Members, questions? Representative Liebling.
Thank you, Madam Chair. Thank you, Representative Zerwas. This is another really important issue, another example of a big unmet need in the state where we are. You know, we think we're providing a lot, and it turns out to be less than we think we're providing because of these kinds of issues. I wanted to ask the testifier, if you would, to describe for the committee sort of what the process is right now. We can't really see each other. Sorry about that. Yes, ma'am. Hi.
I can hear you.
Okay. So if you would describe for the committee what the process is, like how does the vendor figure out when somebody owes money, when they have a spend down, how do you figure out how much is left of their spend down and all of that, because I don't have a precise understanding of this, but I know it's very complicated and difficult. So could you just give us a little more detail of that?
Yes, I think, Representative Liebling, it's a great question. I think I've had this explained to me and diagrams drawn multiple times, and while it does help, I still struggle to grapple with it. So, Mr. Hancock's.
Yes, Madam Chair and Representative. Typically what happens for the provider is that we don't usually find out about the spend down until after it's been applied. So when we submit our request for reimbursement on a monthly basis, the individual, the recipient of services, may have already assigned their spend down to one of their multiple providers. It could be their pharmacy, it could be their PCA provider, et cetera. If we're the target of that spend down, we don't know that until we receive our feedback from Department of Human Services informing us that our reimbursement has been reduced by the amount of that spend down. So, for example, if we submit an invoice for $1,000 for PCA services, we might get a payment of $800, identifying to us that the other $200 was deducted because of a spend down. It then becomes our responsibility to track that down to the recipient and attempt to collect that $200 or whatever the dollar amount might be from those individuals. Now, as you've heard in my testimony and as you heard from Ann Henry, who testified a moment ago, in many cases, because of limited income, that individual may not have the ability to make that $200 payment. Oftentimes what we're able to do is perhaps to negotiate with that recipient a payment plan So they might say, well, I can pay $25 a month. If that spend down is equal to that $200 every single month, and they're only paying $25 against it, it's kind of like paying only the interest rate on your credit card bill. You're never going to get ahead of it. And it creates a very strained relationship between the service provider, or it can, between the service provider and the recipient of the services as they attempt to collect that debt. We come to the end of a fiscal year, and if we're not able to collect those debts, because in many cases, individuals simply don't have the ability to pay. It's not because they don't want to, not because they don't want to be responsible participants in the purchase and delivery of their services. They just simply don't have the income to do so. We end up writing it off. You heard me identify that, for example, I'm probably over-answering your question, Representative, and I apologize, but you heard me say that right now at ACRA we're standing on about $70,000 worth of debt. In 2013, People Incorporated for Mental Health Services wrote off $230,810 in debt. In 2014, that same organization wrote off $310,147 in debt related to spend downs. South Metro Human Services in 2013 wrote off $102,760 in debt. In calendar year 2014, that same provider wrote off $118,368 in spend down debt. And there are other examples that could be shared. So, again, Madam Chair, Representative, I'm sorry if I over-answered your question, but I hope that was helpful.
Thank you. That was helpful. Representative Zerwas, to that point.
Well, and Madam Chair and members and Representative Leland, one of the things that really surprised me and made me so interested in this approach is the variability that the providers have each month for each client. And it sets up this system where there's a race to bill out last. And what ends up happening is 1 month you might get some money from the state and have a $200 bill from the client. The next month you might get a little bit different, and it might be a $12 bill for the client, and the next month so it's never the same. It's never standardized. It's for the people that are trying to help the client manage the money. On the other end, they don't have a set, you pay $200 a month to this provider, or $20 a month to this. It's different every month. It's something that I think any Minnesotan would be confused by on that process of what providers get what checks, what month, and then you take on that they're living at 75% of the federal poverty guideline on top of it, plus they're dealing with the set of health circumstances that they're dealing with. It becomes a very difficult problem, and one that when I saw just how different, I thought, well, if you knew each month you got to get $17 from this person, but there's no rhyme, there's no reason, there's no system. And so, that being said, the amount of time and resources and effort, and then you get to the point where how much time and effort are you going to go after the individual who spends down to 75%? They don't have an extra $4, but they have a $12 spend down this month. And the next month they have a $17 spend down. And it just, so that's what becomes so difficult with trying to track all of this down, keeping the books and the records. It becomes a nightmare for these providers.
Madam
Representative Liebling.
Thank you, Madam Chair. Thank you, Representative Zerwas. That's kind of the nightmare scenario that I want people to fully grasp when we talk about this issue. And just to be clear, though, am I right in thinking that at the point when the vendor gives the goods or services, they don't know, or can they find out what the person's spend down is going to be? No, right? So it's going out the door. So you're delivering whatever you're delivering, not knowing whether you're going to ever be paid for it or not, right?
And what
Representative Zerwas.
Exactly right. And what percentage is kind of hanging out there to be collected? It's like selling someone your car with the IOU from Dumb and Dumber, And he goes, don't worry, guys. I got a whole briefcase of IOUs. These are good. Trust me. And that's what we're expecting our providers to do month after month after month, is to just wholeheartedly, and they care about their clients, and they care about the people they're providing service to. But but they don't know what they're going to put out there that could potentially be uncollected. And then, as they're in a very tenuous situation, trying to provide services for folks on one hand, and then reminding them, hey, you owe me $22 on the other hand. It becomes a very difficult relationship in that structure.
Thank you.
Members, other questions?
Matt?
Representative Mulry.
Not a question, just want to make a point, and I agree that I support your bill. I support your bill, and I understand the situation it puts them in, but let us not forget the situation that the clients are in, trying to, scrape together enough to eat even, and things like that.
And Representative Zerwas.
And Madam Chair and members, I 100%, and my next bill deals directly with that, with looking at the spend down. I think the reality is I hear from it. I have quite a few providers in my district, along with clients, and I think I'm hearing for it on both ends. And I think that's what is so compelling about looking at this area for reform, because we're looking at a broken system. It's not good for the state, it's not good for the providers, and it's not good for the clients. So at some point, between all the different options here, it behooves us to find something to do.
Mr. Hancock.
Madam Chair, if I may, Representative Mullery, I thank you for bringing up that point, because I was kind of chomping at the bit here to make that point myself. So thank you for bringing that up. If I can just dovetail on that for just a moment. I've testified and I've talked about the impact that this circumstance can have on providers. But and I agree with you, Representative, what's more important and what is an even more poignant part of this issue is the impact that this has on participants, the recipients of services. Because oftentimes, or sometimes when this kind of a situation occurs and there becomes a challenge between the provider and the recipient to collect that spend down, oftentimes what a participant will do is they'll cease services with one provider and move to another so that they can get away from that. And what that can create is a horrific interruption in services and opportunities for that participant, for that recipient of services. And that's, I think, the broader and more important issue here. As a provider agencies, part of our responsibility is to conduct our business. But the larger issue here and the more poignant one is the fact that it could cause significant and serious interruption in services to recipients. So Representative Mullery, thank you for addressing that point to us. I had wanted to make that point myself. Thank you, Madam Chair.
Thank you. And if I could just ask a brief question to either one of you. I'm just wondering, obviously it's a confusing process, and in some cases isn't serving the clients well or the providers, and like Representative Zerwas said, the system's kind of broken. So understanding that this bill is certainly a step in the right direction, and a big piece of this is the financial piece. I'm wondering, is there room for reform in terms of how these programs are delivered, kind of the mechanics of it? And it's probably a larger discussion, but something to work on maybe down the road or next session. But are there things that could be done at the state level to kind of streamline and simplify the process that would be at all helpful both to the providers and clients? Or is it more just this financial piece?
Well,
Mr. Hancock.
Madam Chair, I think that's an excellent question, and my simple answer to that question would be yes. And I know that there are several people in the room here that would be more than happy to sit down with you outside of this committee hearing to discuss what some of those strategies, very doable strategies, might very well be.
Okay, well,
Yes,
definitely a valuable conversation going forward. So just curious, and yes, to negate the financial piece obviously is unwise because that's a huge part of it. But to what extent there's other pieces of the wheel that we could put in place, be very interested in doing that. So members, any other questions? Not seeing any. Representative Zerwas will renew his motion that House File 658 as amended be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Zerwas.
Thank you, Madam Chair. Thank you, members.
And Representative Zerwas, we have one more bill up of yours, House File 559. So Representative Zerwas will move that House File 559 be re-referred to the Committee on Health and Human Services Finance. And Representative Zerwas, you have an A1 amendment.
Madam Chair, that will be my motion, and I will move the A1.
Okay, Representative Zerwas moves the A1 amendment to get the bill in the order he would like. All those in favor say aye. Aye. Those opposed, no. Motion prevails. Representative Zerwas, to your bill as amended.
Thank you, Madam Chair and members, and kind of going right along with that, House File 559. This bill brings equity for persons with disabilities and seniors who need MA by increasing the income and asset eligibility consistent with other groups. And Madam Chair and members, I won't belabor the point as it's been covered here already, but currently persons with disabilities and seniors are limited to no more than 100% of the federal poverty level of their monthly income, which is $973 a month. Or if they have over 100%, then if they spend $974 a month, members, then they have to spend down all the way to 75% of the federal poverty level, which is $730 a month. Every other group on MA now has an income limit at or above the 133% of the federal poverty level, and this bill would propose to bring us into parity with that. The bill would also look at the asset limit, which is now $3,000 for an individual, and that hasn't been increased in about 30 years. Members, the increase in the spend down limit will mean that about 12,000 persons living with disabilities will have the health services they rely on covered, and the home care and providers will be paid at twice the value of state cost for the increase due to federal Medicaid matching funds. I think that's important to think about as we talk about this as a policy issue. Minnesota's policy is to encourage people with disabilities and seniors to live in home, live within their communities, and stay active, engaged with our communities. The low income and asset limits really are significant barriers to that. It's a policy that dissuades people from being their best and performing to their highest potential, and that's something that I think we ought to take a serious look at. And with that, members, there are a few testifiers. They know what the heavy agenda tonight that they've been asked to keep their testimony brief, but we're very grateful that they're here to share their stories.
Thank you so much for being here. Ms. Henry.
Thank you. My name is Ann Henry again, and I'm with the Disability Law Center at Legal Aid, and I'll be very brief. I think you've all gotten quite a lot of information about the problem. Raising that income standard is really something that has been deferred for many years. I think the last time we made a step was 2001 on the income side, and as Representative Zerwas said, it's been about 30 years on the asset side. So these folks who are really on medical assistance because they can't get the services they need in any other way in our society are really, really stuck at the very bottom. And I would just like to follow up with the point that Representative Quam made on the previous employed persons with disabilities. Because of our budget rules and process, we cannot get credit for the benefits of allowing people to keep more of their money. Most of the money that involved spend downs are people's Social Security, and if we let them keep their Social Security, they could pay more of their own bills, and we wouldn't have so many other programs that people had to sign up for with all those administrative structures. So I think that's important to keep in mind. And with that, I just urge you to please move ahead toward equity for people with disabilities and seniors on medical assistance. Thank you.
Thank you. Welcome to the committee. If you could introduce yourself and proceed.
Oh, yeah. Hi, my name is Kristen Huskamp. I am a licensed graduate social worker, and I work with Elaine Beckman as a former independent living skills specialist, and I'm here just as a sister with her testimony today. Thank you.
Thank you.
My name is Lane Beckman, and I live in Brooklyn Center. In 2009, I underwent surgery to remove a large brain tumor. Without the brain tumor, I knew I would have died, but there was risks that carried with any brain surgery. when they went to remove the brain tumor, it was a sticky type of brain tumor, so they just about got it all the way out of my brain, and it sucked to the side of the wall, and my entire brain wall collapsed, causing a massive hemorrhage, or i.e. a stroke, across both sides of my brain, which caused me to have to well, sorry. I'm going to back up a little bit. Before my stroke, I was an extroverted multitasker whiz. When I was 14, I was a certified nursing assistant, and I have degrees in paramedicine and nursing. After my stroke, I went from an IQ of 160 to a third grade level. I had to relearn how to walk, talk, read, and write all over again. My years of multiple therapies at Courage Center, my recovery has exceeded all expectations. But I struggle with my organizational skills. I have short-term memory deficit. When I overextend, I need to go to bed for a long time to recover. I became eligible for medical assistance, MA, and the waiver services after I spent my entire $401K I had built up over 30 years of working. I used to love buying the whether it was Starbucks or Mocha or whatever, but either way, I really enjoyed the big cup of of coffee, and I'm assuming most of you know that a big cup of coffee, it's like $4, $5 probably most places. And I used to love doing that, but now with food stamps being cut, I went from $156 down to $28, and 1 month with no notice at all. But that's a week's worth of lunches to me. You know, get a gallon of milk, do a candy bar or a power bar, excuse me, and just try and make it stretch. I'm thankful for the MA waiver services that help me live independently. Without my ILS service worker and my medication nurse, who comes in every week on a Thursday to set me up for the next week, I would totally, what we call foobar my meds, and would not be able to do them at all. Which, to be honest with you, is very difficult when you're coming from a nursing background and you can't even set your own meds. That's kind of ego tech time. I survive. I used to be a flight nurse and a emergency room nurse, and I flew helicopters. I didn't fly them. I was a nurse on the helicopters. And I had a lot of things that I could do in the HealthLink or whatever organization is out there now. So the thing is when I walked into the room, the doctors asked me what to do, and I would tell them. The biggest thing is why I feel the MA income and asset standards need to be increased. One, I get a monthly stipend from Social Security Disability that is $1,195 a month. But I'm expected to pay, like a few of you other people have said, I expect to pay $466 for my medical support services every month in order to start MA paying my waiver services. This is what is called the spenddown. I pay $500 in rent and do household chores. After paying my rent and my MA spend down, I have $229 left of SSDI. So after rent and SSDI, I don't have much left. I worked my life so hard, and after my, sorry, this is where it gets kind of tough. After paying my rent and MA spend downs, I have $229 left of that SSID income to pay all my other needs. Most of the time I don't have enough for food, and at $28 a level, $28 a month, there's not much you can get. And as you can tell, when I get stressed, I start to go backwards a little bit with my talking. So if there's something that's not making sense afterwards, please see me if you have questions. I worked hard and my whole life, which was started at 14, and I should not have to go into deep poverty in order to get the help I need while I'm back on my own feet. I'm trying to make a better life for myself, and it feels like I'm working backwards rather than for my own insurance, my own business. The other thing is that I went from a six-figure income to $14,000 a year. I would like to ask you to start seeing me and others like me raise the medical assistance income assets and spend on standings. Thank you for listening to my story.
Thank you for being here to tell it. We really appreciate it. Is there anyone else in the audience who would like to take a minute to testify? Not seeing anyone. Member questions. Representative Loeffler.
Well, thank you, Madam Chair, and I'd like to thank all the witnesses for their testimony. And I would just like to say to Ms. Beckman, while you shared a lot of what you've done and what some of your losses have been, I think you should realize that you have now a new role to play, and you've played it very articulately, which is to be a voice for others who don't have your ability to articulate the situation your life is in, and you were totally understandable, and you should be proud of being someone who can tell your story in a way that other people can't. And so thank you so much for coming here on that. And I just want to thank Representative Zerwas for bringing the bill forward. He and I have worked on this for, I think, 4 years together, and we're hoping that, in spite of terrible targets, that you'll be able to move forward. And I just want to call attention to the fact that this, while our witnesses have mostly been people with disabilities, this also applies to the elderly. And we've left both the elderly and the disabled behind when we have really been opening opportunities to affordable health care for others that still allows you to have an okay life. And I think that this bill is a good start, and I'm hoping that in spite of a very difficult target, we'll finally start on the road to helping people have the independence that we give so much lip service to. And sometimes if you just want to be cheap, you know, people staying in their own home is the cheapest thing we can possibly do in terms of spending medical assistance, but we make it almost impossible for someone to do that. You know, you've heard what kind of money is left. To pay for utilities, to pay for a phone, to pay for anything is just impossible when you're trying to make it go on $700 some a month. And I think this is something that we just all have to unite around as much as we can. So thank you to all.
Thank you. Thank you so much. Members, any other questions? Representative Zerwas, final word on your bill.
Madam Chair and members, this is a discussion that's been ongoing, and the time I've been here, I'm sure it will continue. The bill in its current form is the full ask. As we move forward to Chair Dean's committee, we'll look and see, and as we go through this entire process all the way until the end of session. My hope, Madam Chair and members, is that there's an opportunity to move the needle in some extent to provide some relief and some help. And with that, Madam Chair, I'll renew my motion.
Okay, Representative Zerwas renews his motion that House File 559, as amended, be referred to the Committee on Health and Human Services Finance. All those in favor say aye.
Aye.
Those opposed, no. The motion prevails. Thank you, Representative Zerwas, and thank you to the testifiers. And thank you to everyone in the audience who took the time out of your days to be here. We appreciate having you here. Next, we'll take up Representative Hancock's bill, House File 339. And as Representative Hancock comes forward, I just want to take a brief moment so that members of the committee know that one of our very own, the chair of the Long-Term and Aging Committee, has a birthday today. We are all very excited about it, and as much as I wanted to sing, what Joe would really appreciate at some point is a hug from people. So in your own free time, that's what he's asked for. He didn't want us to sing. I begged. He said no. But he would like a hug. So just in your own free time, that's how you can wish him happy birthday. So with that, Representative Hancock, welcome to the committee. Thank you for your patience. I just wanted to get that in before Joe scooted out on us if he needed some place to be. But Representative Hancock, I will move that House File 339 be re-referred to the Committee on Health and Human Services Finance. We have the bill in front of us, and I believe we have a DE1 amendment, Representative Hancock.
That is correct, Madam Chair.
Okay. I will move the DE1 amendment to get the bill in the order that Representative Hancock would like it. All those in favor say aye.
Aye.
Those opposed, no. The motion prevails. Representative Hancock, to-year bill as amended.
Thank you, Madam Chair and members. And Representative, I'll be the first in line for the hug. How's that? When we came to Beltrami County, my wife and I, in 1973, it was a nice, thriving community then. Population in 1980 in Beltrami County was approximately 30,000. Today, according to the latest census, it's roughly 45,000, roughly a 50% increase. In 1980, Beltrami County Jail had an inmate population that averaged 21.4. Today, that average is around 130. Roughly at any given time, 70% of the inmates in Beltrami County Jail have some diagnosed form of mental illness. This poses a great concern to us, not only from a financial burden on our institutions, both the law enforcement and healthcare providers, emergency rooms, but it also is costing a great deal in terms of human capital because we're not meeting the needs of these people. And what the delete all amendment, I suppose I should direct that. I do want to give plenty of time I have 3 people coming down from Bemidji to testify today, and I want to make sure that they get heard, so I won't take too long. But I was at a meeting with Senator Goodwin, who called a task force meeting in Bemidji in November to address these concerns. And I was pleasantly surprised that we had not only people from the judiciary, Judge Benshu, we had law enforcement from Beltrami County and from the Red Lake Nation there. We had people from Health and Human Services. We had a lot of mental health providers, both in public and private, and came to the conclusion that this was a concern that wasn't being met with what we had to offer, and we needed a new tool in the toolbox, if you will. And what this bill proposes is that, and it's a one-time appropriation of, I know this isn't the Finance Committee, but it is in the bill of $1,500,000 for Beltrami County to develop
a comprehensive mental health center that is a sustainable integrated care model. It's to be done in collaboration with existing services. We're not trying to supplant anything. And it should be done in a manner that's patient-centered, culturally competent, and based on evidence-based practices. Being that this is a model that we need to duplicate throughout the state, and we're not trying to invent the wheel here. There are other models in Texas and Florida and elsewhere that we can draw on, but we are asking then the Commissioner to evaluate this data on not only how do we save hospitalization and incarceration rates, but also how do we improve our human capital in terms of really providing the mental health that is needed for these people. And with that, I think I'll be happy to take any questions concerning the bill itself, but I would like the testifiers to elaborate a little bit on not only the need, but the fact that I think we might be the poster child for the situation, but we also, I think, have the apparatus and the stakeholders in place to really provide the solution. And I think they would like to testify to that end.
Welcome to the committee. If you could introduce yourself and proceed.
Thank you, Madam Chair. And Representative Hancock, my name is Ernie Beitel. I'm the Chief Deputy Sheriff of Beltrami County, and I want to thank the committee for allowing us the opportunity to come and testify today. I'm here today as part of a team to offer information and answer any questions the committee may have regarding the establishment of a regional health care facility in Bemidji. In essence, a one-stop shop for anybody in mental health needs. Bemidji and Beltrami County are unique, but one of the areas that we do lack in is the ability to help people that are in need of mental health. These facilities are available in Minnesota, but they are lacking in northern Minnesota, and particularly Beltrami County. Unfortunately, because of that, the Beltrami County Jail and jails in outstate Minnesota become the largest provider for people in need of mental health care. In 1980, we had an average daily population of 21 inmates. Today, we exceed that by of more than 120 inmates. Over the 35 years, we've grown over 600%. That's 3,000 people on an annual basis that come through our doors at the jail, while our county population has only increased 50%. In 1980, we had 0 inmates with mental health issues. Today, we are, through our screening process, we're able to identify 70% of our jail population as having a mental health issue. That's 2,100 people coming in and out of our jail with a mental health issue. This has stressed Beltrami County and our community's capability of handling the situation. It has become a crisis for us. Jails are not the place for people in need of mental health, but because of the lack of the programs in outstate Minnesota, particularly in Bemidji, the jail ends up being the provider. We have proven crisis programs in Minnesota and in Bemidji, and these are, and there are great care facilities throughout the state, but none of them exist in northern Minnesota. For those people in need of services, it is with great amount of work, great expense, and sacrifice for these people to seek those services. Beltrami County needs a regional mental health center, and I urge you to support the collaborative and community-based effort to make this possible. Thank you.
Thank you. Welcome to the committee. If you could introduce yourself.
Hi, Madam Chair and representatives. My name is Becky Secor. I'm the Director of Health and Human Services in Beltrami County. And I come forward to support Bill 339. I, too, have seen over the years the increase in number of people that end up in the jail system versus getting the right services that they need at the right time. Because we don't have a detox center or a psychiatric hospital within any reasonable distance, a lot of times the jail becomes the service of last resort. So many people that are in detox, suicidal, or have massive behavior problems or a psychotic incident end up getting their services in our jail instead of in the appropriate setting. I also want to tell you that there's something unique about Beltrami County. Because we have a lack of resources, we've learned to come together and collaborate. Our providers, our local government, our law enforcement, and the people that are actually needing the service, we do work well together. We just don't have what we need to provide those supports locally. And it puts a huge demand on all of the systems, not only law enforcement and corrections, but our juvenile center, our schools, our hospitals. We're all overburdened because we don't have the right resources. We have the right people. We just don't have the capacity to build what we need at this point. All of us come together to, I guess, seek your support in helping us come up with something innovative that uses our assets, which is our ability to collaborate, to build something that can be replicated across the state. We do believe we want to find something that is evidence-based, financially sustainable, and works with the services that are already there. We have wonderful crisis services. We just can't access that level of care. So we're driving from Bemidji, Minnesota to Fargo, Duluth, the cities. It's an enormous burden on an already strained system. We know that we have a high level of need. We just need to figure out how to use those magic collaborative partnerships to bring together a program that can really meet the needs of our community. I hate seeing people suffer in jails because there's not the local capacity to serve those people. I guess I seek your support in supporting Bill 339, and thank you so much for your time.
Thank you so much for being here, and thank you for the work that you do. Welcome to the committee. If you could introduce yourself.
Thank you, Madam Chair and Representatives. My name is Jeffrey Lynn. I'm the Social Services Division Director for Beltrami County Health and Human Services. I'm here to support this bill, and I want to just mention that in Beltrami County, what we need is a place that people can go either on their own or with the assistance from law enforcement or our crisis teams, and that can address their immediate safety needs of the individual by offering a safe place and for short-term needs to be met, and then to provide linkage services to our services that are available within the community. One of the things I want to elaborate on is the collaborative efforts in Beltrami County. Several years ago, we were trying to transport, we were unfortunately having to transport people across the state to, oftentimes outside of the state of Minnesota for mental health services. Our Sheriff's Department and ambulance services were being forced to do these transports. As you know, both of those enterprises are very expensive. What we did collaboratively with our local mental health center and our entire region, which includes Lake of the Woods, Beltrami County, Hubbard County, and Clearwater County, is we developed a protected mental health transport program. That program now transports people all over the state, and as I said, some of the places that we go are Duluth, Grand Forks, Fargo, Thief River, the Twin Cities, Brainerd. You'll notice none of those facilities are within 90 miles of Beltrami County, because we have no mental health facility that's able to address those needs that we're talking about. The miles that have been put on in 2014, over 60,000 miles were spent transporting people outside of our community. When these people go outside of the community, it makes returning them to the community with services in place very challenging. The hope is, by bringing this forward, we'll have a local facility that will be able to help with connecting these people with the services that are available so they don't need to be removed from the home, so they don't need to be placed outside of our community. That's why we're asking you to support this bill.
Thank you so much for being here. Is there anyone else who wants to testify to the bill? Ms. Abderholden? Welcome to the committee.
Thank you, Madam Chair. Members, for the record, Sue Abderholden, Executive Director of NOW Minnesota. This may be as easy as a couple of commas. I was not planning on testifying. I think, as you know, we have, there are several bills, actually. There's the Protected Transport Bill to have that be funded under Medicaid, Representative Albright's bill to actually create more crisis beds. like they just recently did in St. Louis County. Our concern has always been we wanted to make sure that people can access mental health services without going through police. And unfortunately, in the language, we are missing some commas, because the way it is now, it would only be people who are under arrest or subject to arrest and are experiencing a mental health crisis. When we had actually helped draft this language, and somewhere along the way, and it wasn't available, the amendment wasn't available in the Senate, it should actually be for individuals under arrest, comma, subject to arrest, comma, people who are experiencing a mental health crisis, or, comma, or under a transport hold. Because the last thing we want to do is to say the only way you get into the mental health system is if a police officer brings you there or you're subject to arrest. And I would be surprised if you wouldn't, disagree with me there. We don't want that to be an incentive to go in that direction.
Representative Hancock.
And to that, I don't think that is the intent of the legislation by any means, no. The language that I read here is it's model may include mobile crisis residential, outpatient services, community-based services, so it's certainly designed with the idea of incorporating a collaborative effort to provide the service.
So, Madam Chair, that's on line 1. I'm sorry, that's on line 1.8 and 1.7 and 1.8.
Okay, so if we can maybe have staff talk us through if there's a way we can do that, just a technical amendment to put the commas in the way they need, or to have it try to accomplish what Ms. Abderholden, and then discuss that. Representative Hancock?
Madam Chair, we could certainly do that, or we could certainly make a commitment. If I'm assuming we would travel to Health and Human Services Finance, we could certainly work to put the bill to incorporate the concerns that the testifier has.
Representative Hancock, I think you're probably onto a better idea, just to make sure that it is accomplishing exactly what Ms. Abderholden is spelling out, and if there's any other word additions that need to happen. So with the intent that that can get worked on between here and this committee, I think would probably be a good way to do business to make sure that it is in fact getting accomplished the way we need it to. So thank you, Ms. Abderholden, for your input. We appreciate it. We do have a question, Representative Mullery.
Oh, yes, thank you, Madam Chair. And Ms. Abderholden, maybe you should stay, because I had a question for Representative Hancock, but you can probably answer it better. Is this, I went to some meetings over at DHS over the interim on this subject. There was a workforce group that was created, I believe, under Senator Goodwin, and she was always talking about a Orange County hub, and I believe, I think I was at the last meeting of the workforce, and they had something like that. Is this one of the bills coming out of that work group over DHS that Senator Goodwin, I think you were like a co-chair of that group. Is this one of the bills coming out of that? That's my first question.
Ms. Abderholden.
Madam Chair, Representative, that work group looked at the Florida model but did not recommend it. And I don't have the report with me, but basically the report said that in terms of the funding priorities, making sure that our crisis teams are fully funded and that we can obtain insurance for it was important, looking at crisis beds, but they did not support the Orange County model.
Okay.
Representative Mullery.
Madam Chair, my actual question was, is this one of I got the report at the end of our group, but I didn't confess I didn't read the 60-page report, all of it. I mainly was there on the juvenile, and so I read that part. Is this one of the bills recommended in that report?
Ms. Abderholden.
Madam Chair, Representative Mullery, that report did not recommend this bill, and I can provide the summary of that report, but it didn't end up recommending it.
Okay. And
this bill is a little different than the other one. I'm sorry.
Thank you, Madam Chair. My second question is, and I think I might have asked that when I signed on the bill, Representative Hancock, is it going to, I want to make sure it's not just Beltrami County or the 4 counties Because if we're going to put a lot of state money in, I'd like to see it handle the cases from quite a few counties up there. Is that going to be the case, or is it just Beltrami or the 4 counties?
Madam Chair.
Representative Hancock.
Representative Mullery. I've been working closely with Senator Goodwin, and I think what we're doing with this bill, we're not only trying to build the model, which the original 339 would do, and the reason we're asking for an additional $1 million is we're actually trying to build the program itself as a model for the rest of the state. And I think rather than rely on some of the grant money that was accompanied with a different bill, and that bill may still go forward. I'm not privy to exactly where that bill is going. But what we're saying here, I think in order for Bemidji and Beltrami County to build the model, we need some seed money so we can get some grant money from other foundations to help actually construct and build this model that then can be replicated with some grant funds from the state and elsewhere. So I think rather than rely upon Bemidji applying for a grant from the other bill, what I'm asking for here, and I thought this was the best approach, to build the model, we need a commitment from of $1 million in order for us to seek funding elsewhere. And that's where I'm at with that, and I...
Representative Mullery.
That wasn't my question. My question was, can other counties use this? There's a lot of counties up there that need this type of facility.
Madam Chair.
We're probably not going to build one in each county.
Representative Hancock.
Madam Chair and Representative Mullery, I think if we read a closer look at the DE1 amendment, that's exactly what it's proposing to do. It's proposing to build a model that, as we mentioned, does use community-based services and is culturally competent and evidence-based practices. And then it is to report the data to the commissioner with the idea that the commissioner then can evaluate, provide information to both the chairs of the minority and majority party in this legislative body that we're here today, so that the recommendations then on how we proceed throughout the state comes back to here with the results of what we're trying to do in Beltrami County. And so, yes, directly, I think it is. And the reason for the funding up front is, I think, in order to build a model, we need some initial money to do that, and then report back on how the model is really working, and then we can make adjustments as it goes throughout the state. Hopefully that answered the question, maybe not.
Representative Quam. Okay. Representative Freiberg.
Thank you, Madam Chair. Mr. Abderholden, you may not want to leave yet. So I'm glad you came down, because you sort of answered half of my question. I mean, half of the question I was going to ask. I mean, it seems to me that mental health, the shortage of mental health professionals is a problem, not just not just among the prison population, but among the general population as well. So I'm glad you provided the comment that you did. It also seems to me that it's a problem not just in northwestern Minnesota, but statewide as well. And it seems like this is something that, it's not phrased as a pilot project, but it seems like something that could or should be scaled up so that, as many people as possible, and I think Representative Mullery's question relates to this as well, can take advantage of this, although, with the targets that came out yesterday, I don't know that scaling it up is going to be a possibility, unfortunately. I guess my question is just, it does seem somewhat limited in scope. Is this something that NAMI supports?
Ms. Abderholden.
Madam Chair, Representative, we were not opposing the Beltrami County model. This dollar amount is a lot higher than what we had seen offered in the Senate. And, just as a reminder, when we received an additional $1.5 million for the mobile crisis teams in 2013, we were ecstatic, and that was for the whole state. And so it is a lot of money for the mental health system. I have no doubt, I know Beltrami needs it. We hear, from other counties as well. So we were okay with starting this as a pilot, not necessarily tied to Orange County or to Texas, but also looking at some of the models in Minnesota to see in a very rural part of the state without a hospital right there, what other things that you could do. So we're not opposing this particular bill,
Okay.
With the commas added.
Representative Freiberg. And maybe one of the testifiers, I don't know which one, but I think part of the question is if we're going to be looking at giving all this money to one county, are we looking at this being a regional resource? I think the concern of some of the members around the table is this, there's a shortage of these types of facilities in this part of the state. And while we recognize that, I think the question is, will this be a regional resource beyond just the boundaries of Beltrami County?
Madam Chair, I am also sitting on a group called the Adult Mental Health Initiative, which is funded through state funds, which includes Clearwater County, Hubbard County, and Lake of the Woods County. We have worked collaboratively to address the crisis transportation needs and would continue to work collaboratively with those counties in providing those services. Beltrami County does happen to be a regional hub. We sit kind of in the center of 3 reservations, Red Lake, Leech Lake, and White Earth. So we are used to working and providing services that kind of reach out to those partners in the area. So we are regionally connected and, of course, always want to serve and work with our local partners and regional partners.
Okay. Oh. So just to clarify, so this would be accessible and a resource to not just Beltrami and the counties you just mentioned, but potentially could be a resource to all the counties in that area of the state that don't have access to these types of mental health services.
I would
Ms.
say
Secor.
yes, mostly because there's really not a lot of choices. All of those counties are driving to other states and other facilities hundreds of miles away to access services. So absolutely we would do our best to work with local and regional partners.
Okay, for the model to spread as far as you can make it possible. Representative Freiberg.
Thank you, Madam Chair. I guess maybe just a suggestion, as long as there is going to be some work on clarifying the language so that it's not only applicable in the criminal justice setting, maybe the language could also be clarified to ensure that this is and this will function as a regional center. I do see on line 1.10 a reference to northwestern Minnesota, which to me suggests more than just the one county. However, the way it's worded, I don't. It sounds. It sounds like I don't really know what "and" northwestern Minnesota is modifying. I guess if it could just be made clear that the people served are from that region, I think that would be a good thing as this bill moves forward.
Thank you for the suggestion, Representative Freiberg. Representative Liebling.
Oh, I'll pass, Madam Chair.
Okay, Representative Zerwas.
Madam Chair and members, I think this is a good bill. It's needed. What we're trying to do, and I have the larger grant-based bill, and Representative Hancock has this one specifically for a diversion program in Beltrami County, servicing the area. And I think you have to realize what the status quo is and what the current challenge is. Right now, as law enforcement deals with individuals having a mental health event or individuals that just flat out don't belong in jail, the travel encumbered and the closest facility or bed, we are talking about a serious trip of hours or hundreds of miles. There is not the availability. And what ends up happening in the metro area, let alone in this part of the state, is you end up, quite frankly, having people in county jails that don't need incarceration. They need treatment. They need services. And this is this is exactly what this bill is designed to do, is keep people that don't need to be in jail but need a mental health intervention and treatment into the appropriate setting. I know in my time at the sheriff's office, just Anoka County, our crime lab was located within the jail facility, and the Anoka County Jail at that time had every single day people in that jail that did not belong in that jail solely because there were no crisis beds available. Earlier this winter, I was at the Sherburne County Sheriff's Office meeting with my sheriff, and he asked me what I was working on, and one of the things I mentioned was the grant bill that's similar to Representative Hancock's bill, and my sheriff said, Nick, we're dealing with 2 people right now that have been brought in because they were involved in an altercation, and the one individual is going through an episode of mental illness and is downstairs in one of our cells, and we cannot get him to stop hitting his head against the wall. And there are no beds within 400 miles available to bring him. And so I know it's a huge issue, it's a pressing issue. There is not a silver bullet for dealing with mental health crises in our community. But if we don't stop sitting around waiting for the perfect solution, we're going to sit around and get no solution. So at some point, we got to do something. And I think this is a great idea. It's been effective in other states, and I would urge us to support Representative Hancock's bill.
Okay, members, seeing no further discussion, I will renew my motion that House File 339 as amended be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye.
Aye.
Those opposed, no. The motion prevails. Thank you, Representative Hancock.
Thank you, Madam Chair and Committee.
Members, we are going to do one last bill very quickly. Representative Norton's House File 1056. And then we will be breaking for caucus and coming back at about 6 or 6:15 in the basement. So Representative Norton, welcome to the committee. I will move that House File 1056 be re-referred to the Committee on Health and Human Services Finance. Representative Norton.
Thank you very much, members. Some of you have heard this bill before because it's been through several committees, including the Long-Term Care Committee, of which some of you are members. So I'm not going to go into great detail. Actually, the bill brief is excellent, as I mentioned in the last committee, but I'll just give a quick overview. And I have someone from my community that's come that some of you know to give a 2-minute testimony. He said he's refined it down to that. So this particular bill directs the Commissioner of Public Safety to create a lifesaver grant program to assist law enforcement agencies with the costs for training for law enforcement in order to, and it's all voluntary, in order to train the law enforcement to utilize the technology so that when seniors or adults or with a disability or children, and the testifier that I have today is a father of a son with autism, when they wander off, this technology is able to track them down so that they are brought home very quick and safely. And so there's no appropriation in the bill, as you'll see, and I know this isn't a finance committee, because this is an absolutely scalable bill. We figure about $300,000 would fund it for the whole state, assuming everyone wanted to participate. We know that won't be the case, so it's completely scalable with however much money someone wants to put into this program. Just for history, 30% of Minnesota's 87 counties, which is a 26 total, already have some sort of program similar to this implemented. However, within those counties, there are also 22 other agencies working with them, so it's a total of 48 combined agencies that are currently participating in this training and the program associated with it to help find and save individuals that wander off. So with that, I'm going to just let my testifier do his 2 minutes and we'll be done.
Welcome to the committee.
Madam Chair, members of the committee, thank you so much. Happy birthday, Representative Shoemaker. 2 minutes. Imagine this. Going to take you back to the scenario. Imagine a loved one, a parent, grandparents that may have Alzheimer's. Imagine a child that may have Down syndrome, autism. Now imagine you're giving them 24/7 care of that child, that loved one, and all of a sudden that person goes missing. Can you imagine the anxiety you're going to feel, the heart where it's going to go? Then all of a sudden you call the police, and when someone goes missing, it's the responsibility of government, i.e. police and fire, to go find that individual. And that person may not be able to defend for themselves. Days go by, maybe weeks, maybe seasons. And the countless nights that you go through not knowing where your loved one is. I've been on a search like that lasted for 4 days, and that boy was found dead in a pond south of his home. Now take back, imagine this, a transmitter bracelet that we could put on individuals that are very vulnerable. It's an RF frequency, it's better than a GPS. GPS, you're going to lose signals. With this, you don't. It penetrates water, it penetrates subways, it penetrates, you name it. The average distance that law enforcement and fire can find a missing individual is 1 to 2 miles on the ground and 10 to 20 miles in the air. The average length of time to find an individual missing is 30 minutes or less. For full transparency, Madam Chair, I am on the board of directors for Project Lifesaver International, based out of Virginia. Olmsted County, we implemented this in 2007. Through Project Lifesaver, there are many other technologies out there that agencies can choose from. We've had 2,971 searches since 1999, not one fatality. The average time, 30 minutes or less. This saves lives, it saves resources, it saves tax dollars. And can you imagine law enforcement going to a loved one's home and telling them that they found their next of kin dead, compared to going to a loved one's home and saying, guess what, here's your loved one back home. This is a life-saving bill. Madam Chair, thank you and the committee for hearing this bill out, and I appreciate the bipartisan support.
Thank you so much for being here. Members, any questions? Representative Albright has a very short question.
I'm just, for the testifier, I'm just curious in terms of how do you make sure that it would stay on the person or with their garments in terms of, from time to time they might just decide to pull it off. And I'm just curious, how do you make sure it stays with the person?
Mr. Trahan.
Madam Chair, Representative, thank you for your question. Technically, could you cut this off? You could. But through our experience, we have roughly 70 clients on in Olmsted County. We've only had one situation where it's ever been cut off. People do adapt to this. They can go on your wrist. They can go on your ankle. They're very adaptable. If you have to put on your belt loop beside in the back pants, you could do that as well.
Members, any other questions? Not seeing any. Thank you so much for taking the time to be here. Okay. And I'm sorry, Mr. Trahan, I'm not sure at the beginning of your testimony if you introduced yourself. If you could just say that on the tape, that would be appreciated.
My apologies. I wanted to keep under 2 minutes. Brad Trahan, Rochester, Minnesota. Thank you so much, Madam Chair.
Thank you very much. Appreciate it. I will renew my motion that House File 1056 be referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Norton. Okay, members, we will break for a recess until approximately 6 o'clock or call of the chair. So, and whatever bills we haven't done, if you could just slip them back into your folder, and then anything on the table will get cleaned up. So, and members, we will be in the basement when we reconvene. So don't forget to give Representative Schulmacher a hug. And with that, members, we are in recess.